respected chairperson, panelists. So the today's topic is impact of CPAP on the atrial fibrillation substrate in the obstructive sleep apnea. Already the stage has been set by Dr. Manoria so that I can directly jump to my topic. So we are dealing with a patient of obstructive sleep apnea and how to treat the substrate of atrial fibrillation with the help of CPAP. So OSA is a chronic disease which affects more than 20% of the global adult population. One of the major issues in spite of high prevalence is the underdiagnosis of the disease, because it is usually suspected in the patient of the excessive daytime sleepiness. The other patients are usually neglected and they are underdiagnosed. And one of the other major issue is that half of the patient with moderate to severe OSA will be asymptomatic. When we speak about the epidemiology, the prevalence of OSA in India is around 2.4 to 4.96% in men and 1 to 2% in women. 93% of the women and 82% of the men with moderate to severe OSA are underdiagnosed or never diagnosed. It is more prevalent in men, might be because of the body fat distribution or upper airway anatomy or protective effect of the female sex hormone. Not going into the definitions of apnea, hypopnea, RERA and hypoventilation. And the polyphenography, overnight polyphenography is the gold standard for the diagnosis. The AHI has already been discussed. So beyond sleepiness, OSA is a prevalent cardiovascular risk factor present in half of the patient of the hypertension, as Dr. Jha has already spoke to us. A high prevalence of OSA has been reported in the patients of atrial fibrillation. The Sleep Heart Health Study found there is a 4-fold increase in the prevalence of atrial fibrillation in the patient of OSA. So what is the mechanism? The OSA leads to intermittent hypoxia, hypercapnia and intrathoracic pressure shift, leading to hyperactivity of the autonomic nervous system. All these factors are one of the established factors for atrial fibrillation, or they may contribute with the atrial fibrillation. So apart from being associated with the high prevalence of AFib, the untreated OSA reduces the effectiveness of the treatment as well. The patient with AF who have concomitant OSA compared to those without show a lower response to the antiarrhythmic drug. So OSA, the mechanism will go like this. The OSA will lead to negative intrathoracic pressure, which will increase the afterload, which will cause LVH, and LVH will lead to atrial remodeling. We will be speaking about the atrial remodeling here. Again, the negative intrathoracic pressure will lead to atrial stage and it can cause atrial remodeling. Obesity per se will cause LVH and can lead to atrial remodeling. Increase in the vagal activity, which shortens the APD and the effective refractory period, will increase the initiation of the atrial fibrillation. Increase in the sympathetic activity will lead to AF initiation. And hypercapnia and hypoxemia will cause oxidative stress and systemic inflammation, and eventually it will lead to atrial fibrillation. So OSA is independently associated with the incidence, prevalence and severity of the atrial fibrillation. However, the impact of OSA management on the electrophysiology substrate has not been evaluated till date. This randomized prospective study evaluates the impact of CPAP therapy on atrial substrate in the patient of OSA with AFib. So this is a prospectively evaluated, the study prospectively evaluates the impact of CPAP treatment on AF substrate. The study has recruited the consecutive consenting patient with the AHI index more than 15 diagnosed on the overnight polysomnography. All patients underwent the invasive electrophysiology study with a high density RA mapping at the baseline and after the 6 months. After the initial procedure, participants were commenced to the CPAP therapy or remain without OSA treatment depending upon the randomization. So out of the 321 patients who consented for the study, 156 has the AHI more than 15, out of which 120 satisfied the inclusion criteria and 25 consented for the study. One failed to complete the second EP study, for overall 24 patients. The 12 patients were subjected to no CPAP and 12 were subjected to the CPAP therapy. Any patient with structural heart disease, age less than 18 years, history of prior ablation or a diagnosed patient of OSA with a CPAP therapy were excluded. So patients were randomized in 1:1 ratio. The pre-specified primary endpoint of a mean atrial conduction and the secondary endpoint were mean atrial voltage, mean complex point as a proportion of a total points, mean low voltage conduction velocity and atrial effective refractory period. In the study, they have used the pentaray mapping catheter, which is a biosense Webster catheter. It was used to construct the geometry of a right atrium with the use of a Carto system, and the voltage and the activation map were constructed with the use of mapping catheter. So the baseline characteristics were comparable. The CPAP compliance was high in the treatment group, which indicated the good control of OSA with the use of CPAP. But when we discuss about the result, when we see about the conduction velocity in the patient of a CPAP group as compared to the baseline, it was increased on the follow-up. The bipolar voltage, and it was bipolar voltage which was around 2.17 at the baseline, increased to 2.30, and it was statistically significant. There was a decrease in the low voltage surface area. There was a decrease in the complex points, and the left and the right atrial area were subsequently decreased on the follow-up in the CPAP group. So this is the first randomized study which evaluated the impact of CPAP therapy on an atrial substrate for the atrial fibrillation. The main findings are the CPAP therapy in the patient with OSA with AFib are compared with the untreated patient to know the reversal of atrial remodeling, which was characterized by increase in the atrial voltage, improved of the conduction velocity, and reduction of a complex point. The present study shows the CPAP therapy has a potent mechanistic impact that are observable even in a relatively small group. The association of a CPAP therapy in a OSA with improved atrial fibrillation management outcome have been documented by multiple observational studies across a variety of clinical contexts. This study suggests the untreated OSA negates the efficacy of the rhythm control strategy, and the CPAP therapy ameliorates those negative impacts. In this study, the BMI and the blood pressure remained unaffected, which indicates the reverse remodeling was mediated by the CPAP therapy alone. Although the previous studies have observed the reversal of atrial electromechanical remodeling following the CPAP therapy, but none of the study have done the sequential invasive EP study to characterize the atrial substrate in detail. The present study demonstrates the CPAP therapy alone can at least partially reverse the atrial remodeling in the patient with OSA. The CPAP therapy results in atrial remodeling in AFib and provides the mechanistic evidence advocating the management of the OSA in AFib. One of the major limitation of the small group, there are only 24 patients which were randomized as a 12 patients with CPAP and 12 patients without CPAP. A larger randomized trial may be required to determine the further clinical relevance. Thank you.